Hello and welcome to Making Digital Health Real series. This fortnightly series aims to provide a space to discuss emerging research, share career highlights, showcase projects and networks for those interested in digital health. Before we begin, I would like to acknowledge and pay respect to the traditional owners of the lands upon which we're situated today. Today I'm actually on the land of the Turrbal and Yugara people, and the centre is on the lands of the Wurundjeri people of the Kulin Nation. And I'd like to pay my respect to elders, past, present and emerging. And we acknowledge that sovereignty was never ceded. We also extend this respect to all traditional owners of the lands from which our participants are joining us today. So it's my pleasure to introduce Dr. Kate Renzenbrink from the Eye and Ear Hospital in Melbourne, and she is the Chief Clinical Informatics Officer there. Kate is a registered nurse and health informatician with extensive experience in acute, specialist and aged care, both in metro and regional areas of Victoria. Kate is a strong advocate for person-centred care and consumer involvement in healthcare, using health IT tools such as My Health Record. So I'll pass over to Kate now. Thank you very much for joining us.
Oh, thanks very much. Not a doctor. Well, yeah, not yet, but I might keep studying, and then there might be some kind of
No one will
PhD.
ever know. Let's just keep it. Sorry.
Definitely registered nurse, and very proud registered nurse, and that's what we're talking about today. Thanks for coming along. So really just wanting to present about some of the origins of nursing informatics. Our nurses are really great change champions, but we're being impacted by technology in specific ways. We have a really long-standing history working with information technologies and technologies as a whole, and we have a really big contribution to make to safe and effective healthcare. So using our professional knowledge, our ethics, our advocacy skills. So this talk is, a little bit of history and why history is actually really important to kind of pay attention to with the current things that are happening in healthcare and digital health. All right, so interestingly, like I was looking at up to nursing representations in public, and there's a lot of terrible pulp fiction books that use nurses. They're romance novels, and nursing's always been challenged by probably because we are, we're a female-dominated profession. We've been challenged by sexualization, objectification, all the things that women are challenged by as well. But I actually found some titles that fit with my career as a registered nurse and then moving into digital health. So I'm going to sprinkle those in as we go because, they're kind of really bad, but also interesting in terms of history and where nursing may need to go next. So really interesting, someone called Sarah Di Gregorio was writing about the earliest verifiable kind of case, I think, of human paralysis associated with severe spinal pathology. And they found a young adult male in the Southeast Asian Neolithic community, so 4,000 years ago in what is now Vietnam. And, in that kind of community, they obviously there's evidence that this person must have been completely immobile as a teenager. And he lived until his mid-20s and with a really severe spinal curve. And what we can really tell from that is that someone or many someones nursed him really intensively. They would have had to help with positioning and tend to his skin and to prevent pressure injuries. And, without nursing care, he would have died very quickly within days. So this really interesting article talks about the almost an archaeological focus on healthcare and how we need to actually challenge a bit of this idea of angel in white caps and look further into history for the origins of nursing and also value it now, because these caring principles and looking out for each other, it makes really good health and welfare policy. So modern professional nursing definitely has scientific knowledge and an evidence base, and it's different from what we might call ancient nursing. But this is this organised way of working that I think carries through to the current the current time. And I really like one of the lines that Sandra says. She says, even when nursing is missing from general history books and archaeology studies, it's still in there. You know, in every heroic tale of survival, there is an invisible hand that stopped the bleeding, which is really an interesting idea. So yes, we've got the Nightingale, the prototypical nurse, but this is really kind of a myth. And I'll talk about some of the really problematic parts of her story and her contribution in a second. But the history of nursing proves that you know, there is an instinct to mend, to organise skilled care, as I mentioned, and the idea that we're a profession working in hospitals subservient to physicians is actually really new. So we absolutely know that history can help us to discuss what we need to do in nursing too. The problems with Florence Nightingale are that she was really steadfast in her belief of the supremacy of a Christian and white culture. So she really problematic ideas about order and cleanliness and purity that actually are still a challenge for us in healthcare, because we fail to recognise who is making a contribution and the work at the edges. So we're still very hospital centric, and we're still we've got that hierarchy, that military hierarchy still in place. So just to mention too, so Mary Sokol is really promoted as someone who's been missing from our history, and she worked very differently. She didn't necessarily call herself a nurse, and she had some very brief interactions with Florence. But it's really interesting that we haven't sort of really understood where she fits, and that history has actually been rectified with evidence and fact. She was an innovator, an important innovator, and able to see what was happening and meet the needs of the people around her, even if it wasn't the kind of the Florence Nightingale nurse. So Florence did make a contribution in a really huge way, and she's really the kind of the first person for not just nursing, but for all healthcare, who started really using data and visualization. So this is one of her bar graphs, but I wanted to show you too the data visualization that she did. So that kind of curated view of information that we're all chasing at the moment, you know, understanding that context is critical, and we need that graphical integrity. The EMR can't just be a place to put data. We need to get data out, and we need to see it, and we need it to tell a story. So that blue wedge there are deaths from preventable or mitigable disease, and the pink, pale pink, meant to be red, but it's faded a bit over time. They're the deaths from wounds. So the black wedge represents the deaths from other causes. So Florence was able to collect data, analyze it, and present it in a way that really showed without a doubt that the causes for these soldiers' deaths were infections, and she set about kind of revolutionising how we deliver healthcare and how we look after people. A little bit politically kind of challenging, because the motivation was to get soldiers back fighting. And then I was thinking too that technology goes way back for us. So this is what the kind of senior matron nurses would have worn as part of their days, and women had these if they were running big households as well. But these are the first apps that nurses used, with everything that you need, including the scissors. So kind of the next stage in my career, you know, I started as a graduate nurse at St Vincent's. I ended up working in the cardiothoracic ward at St Vincent's, and one of the first I guess experiences of technology that I had, other than the informatics, where we were obviously doing a lot of documentation and charting, was this thing. So a temporary pacemaker. So really interesting example that I guess, opened my thinking up to how we might use technology and improve it. So after patients had cardiothoracic surgery, heart bypass, they'd spend a day in intensive care, and then we would take over their care until they were ready to be discharged home. And we used these temporary pacemakers with tiny kind of fine cat's whiskers wires inserted into the heart muscle to actually control or supplement some heart rhythm, and until, because things are really unsettled and from the surgery, sort of manhandled, person handled in the surgery. So until that person's heart had really kind of settled down, this is what we did. And while I was in that role, the company, and it may be Medtronic, may not be, switched over to a different kind of device, which just had the LCD display that you can see in the middle, but up and down arrows to press to control for heart rate, as well as the electronic, also the amp, the electric signal and the pulse that we were delivering to the heart muscle to cause a beat. And everyone hated it. Everyone really hated it. So they actually had to move back to the device that had these dials again, and that kind of sensing of exactly where you wanted the heart rate to be, plus the feedback, the sensory feedback that you get from those dials, the haptics of it, was my first exposure, I guess, to usability. And then at that time when I was working, we were doing a lot of campaigning. So I really started nursing while we were undergoing this pretty horrific time in healthcare under the Kennett government, with very, very savage budget cuts. And there was an introduction, a pilot of an application that was designed to measure patient acuity and relate that to clinical care. So basically predicting labour hours and then providing all of these reports as well. Very interesting times, and nurses experience multiple reasons for their challenging workload, and reducing us to kind of time spent and trying to capture that information about patients that will help with rostering didn't feel like enough, and also felt like a threat. So yeah, we're still, I think it's still in use around the place, this system, and a comparison has now been made recently, actually, with a nursing activity score, just to make sure. And this is really what nurses need to do, and what we all need to do in healthcare, is absolutely evaluate the technologies and the information systems and the applications that we're putting in. Is it really helping? Is the premise correct? Has the problem been properly defined? How do we actually deal with nursing workload? And is just watching the system going to help us, or have we got an opportunity to get data out of a system that will really help with us with insights about what nurses do and their contribution and their value, especially in I guess, yeah, really dynamic environment. And it reminded me of something recent that I saw with nurses responding, and this is the Kaiser Permanente Nurses, California Nurses Association, who are actually the second group of nurses to fight for nurse ratios after Victoria here in Australia. So this idea that a body is a machine and the mind is like a computer, that's really coloured a lot of our thinking in cognitive science, and we're seeing it again, this idea that human intellect just relies on a lot of subcategories, and it can all be processed, and we can get data and we can kind of formalize it. So how does nursing sit with that? This is the challenge with a nurse agent, a chatbot AI, and for $9 an hour instead of paying a human nurse with all of the other things they do. So I think that there's really an imperative to understand what nursing actually is, and code our knowledge and our expertise and our interventions. But burnouts are a really big issue as part of this big workload challenge, and we do have a global shortage, and we have a global shortage of nursing informaticians as well. So we as digital health becomes so much more pervasive, we absolutely need to have a really skilled workforce, and I'll mention how we can do that later on. But techno stress, time pressure, workflow related issues with new technologies, they all have to be addressed. And in order to accelerate the integration of the data, health data that we're collecting into our clinical care and into our clinical decision support, so that augmented intelligence, the visualization of data, human computer interactions. I'm so happy that finally we're attending to this in a thoughtful way. So off I went to Bendigo Health. The television nurse there is well, I did some campaigns for awareness campaigns for My Health Record. So not quite a TV star, but got to work on a set, which was kind of amazing. And the society nurse, well, I joined the Health Informatics Society of Australasia, which is now AIDH. And so, getting into kind of nursing informatics, that specialty that integrates nursing science with analytical science and lots of kinds of information sciences. And this is really so we can identify, manage and communicate data, knowledge in nursing practice. So we are the specialists now, the translators, that are evolving into health tech innovators. But nursing documentation, and we do still do a lot of it. Someone I think quoted the other day that it's sort of 60% of our work time, 40% of our work time. So we're really wanting to streamline this and make this more efficient and put things in once so that we can get them out multiple times. And the studies that are coming out looking at this are really interesting. So this is about natural language processing, looking at the symptoms that are documented in free text clinical notes in the record, and being able to predict when a patient is actually on a trajectory of deterioration that may need emergency visits, and how we can kind of interrupt that quickly and early. We're still doing what we're doing, but we're actually accessing the nursing data to increase, I guess, the options available, and it's better for the resident in aged care to stay where they are. And this is really interesting because nursing documentation looked like this when I started. And in fact, I was told to use a green pen, and all of our allied health professionals and medical colleagues were using black and blue. Green didn't show up on the photocopier, and we quickly actually moved to black and blue as well, because we had to photocopy everything to transfer a patient, and it all just got photocopied, put in a big envelope and handed to the paramedics. So nurses have always been informaticians, and I think this is a surprise to people, but we've always been involved in collecting patient data, recording it, sharing it, coordinating it, and using the data to generate new information and knowledge. And I think nursing must accelerate the transformation of the way we use our clinical data, and we need to be digitally enabled. And to do this, we have to invest in informatics education and research, and really robust and evidence-based technology implementation. So I want nurses to upskill in data science and other digital health topics, and really confront and challenge the emerging technologies, so that we get to choose what we apply to our own practice. The burden remains, though, as I mentioned. So even though we've moved to electronic in many cases, EMRs, we still have this big challenge with documentation. And part of that is because we have not necessarily been included in the design of these systems, but the systems don't account for the physicality of our work either. So, we're seeing that change with integration with devices, IV pumps, for example, ICU flow sheet here, but it's really busy and noisy. And again, it's hard to focus in on what is important about that information. So we have to challenge the usability, and we have to design things that really reflect and mirror what nurses do. I think nursing has had a huge role in consumer access to information and the flow of access. So consumer partnership, which is one of our national standards, it's, you know, it's more than just patients being involved in their own health. You know, they have to be equal partners, and it is about equalising the power to the extent possible. So you know, the College of Nursing actually argues for models of care that provide for the right incentives, the right care at the right time, the right price, the right place, the right provider. So absolutely, you know, rethinking the way we deliver healthcare. Nurses have been at the centre of that and the edges of that, you know, advancing their own practice, but also advocating really strongly for care that meets people's needs. So, you know, community care outside of hospitals is where most care happens. And this is just a great example, something that I really was privileged to be involved in when I worked at Western Health, getting a consumer app out to women in their pregnancy. So this really important piece that nurses and midwives stand for, providing understandable and accessible health information, which improves people's knowledge and understanding and recall about their healthcare. And you know, that they need good quality information. It's integral to informed decision making. Yeah, so next part of the career, you know, we're such good organisers and categorisers, and I want to talk a little bit about that. You know, without digital and without automated dispensing, we work so closely with pharmacists to organise around medication management and administration. But what is next, and what can we do? There's recent Australian College of Nursing media release that definitely go and have a look at. The link is there, about standardised nursing terminology. So on the back of an international project to ensure that as we implement EMRs and they grow in use, that we have some consistency in the language, and the data fields are there in order to be able to draw out data which can be analysed and compared and researched so that we can make the value of nursing more visible. So this is about providing a common language for nursing and midwifery. And just a slide, just a snip of the International Council of Nurses, the classification of nursing terminologies here. Founded by the International Council was founded itself in 1899. So, you know, reaching right back into history, and has been working to cross-map and provide a reference terminology so that patient care or client care outcomes can be examined in relation to what it is that we do, and nursing process, nursing diagnoses, which is really big in the 80s and then dropped off a bit, but it's about deciding what the nursing problem is for that person with that person, and then the interventions that we provide so that we can apply our critical thinking and clinical decision making in terms of those interventions, and see the outcomes and link it all back as we normally do with our nursing process. So really challenging, you know, we don't so much solve a wicked problem as just, you know, help stakeholders negotiate shared understanding. So this is something that's gone back to the 70s actually, that you know, the disruptive innovation, the political complexity, I think as information and knowledge increase and the technological development expands what we can do, you know, we need to focus now on the safety, the quality, the ethics, and how we position around this complexity, because we've seen a promise that technology will help us, but it's actually added another complexity, and we've got change complexity as well. You know, so how do we lead through this? I think nursing is really connected to our community, our patients, right across the spectrum of healthcare. And, you know, we absolutely need to address funding models because they're a barrier to coordinated care and that kind of seamless connected care that we're aiming for. One of the things that we've already got in place, but maybe it's not working so well, is this idea of nursing sensitive indicators. So, you know, why should we care about capturing this kind of information? Well, we know if we've got these indicators, these elements that we can record against care, and the key elements of the staff experience, we know it's tied to better patient outcomes. So that's quality patient-client outcomes. We're already doing this as part of national standards, hospital-acquired infections, pressure injuries, falls. These are all nursing-sensitive indicators, but we probably haven't been as sophisticated as we need to, and that designing them into our clinical information systems. There's a heck of a lot of reporting that happens in health services that is very manual, pulling data together to get insights. So, I know we're all on the dashboard bandwagon, but our dashboards absolutely have to be fit for purpose and reflect what's really happening. And here's an example too of how that might look with the indicators from some recent research. And basically at the end of the research, they were like, well, this is really hard. We don't actually know exactly what, pardon me, an emergency nurse is. Some questions remain unanswered, but from what we do know, we know that there's a gap in the literature in really understanding the criteria that we could collect that could better inform where emergency nurses make a difference, what they do, what their contribution is. So very fragmented, siloed sets of safety and quality indicators, as I mentioned. No consensus, not really a national minimum data set of nursing quality indicators either. So these are sort of like the action verb, coupling up with the classification systems that we've got. And how does this then lead into, just tapping into the nursing knowledge? So one of the things that I keep coming back to is this idea of a different type of nursing knowledge, intuition, and challenging this in a kind of a technologically focused world. If it's not documented, it's not done. And if we can't codify it, we can't research it, we can't fund it. So is this kind of idea that nurses think differently or have different kinds of knowledge, is that helping us, or is it even true? This idea about data to insights, and I'll show you something in a second. We've still got this challenge, and I wonder if it's a bit like the halo and the hero archetype, the narrative. So intuition's defined as the ability to acquire knowledge without the use of reason, like a gut feeling. I have had experiences of this in my own career as a nurse. I did everything humanly possible, pardon me, with a patient once who seemed to be good in the numbers, but something just wasn't quite right, and I couldn't place it. And I even did a 12-lead ECG because basically that was the advanced tech that we had, and got people to check it with me. And this is on the cardiothoracic ward. And I was really devastated to come back onto my next shift to find that 2 hours after my shift ended, he'd had a massive heart attack and passed away. And I just had this feeling, can't explain it, but I'm interested in explaining it. I'm interested in making that kind of intangible tangible, if there's a way that we can do that. Humans are overwhelmingly, they think intuitively rather than rationally. We perceive what is around us and what is apparent to us, but maybe, the cognitive biases are really a big problem. So I think nursing needs to grapple with this idea of adding in that humanistic, intuitive approach to clinical care, but you can't integrate into a kind of a science evidence-based medicine. So maybe this is more about the art of nursing, and I'm wondering where digital helps us or stops us with that idea. This big idea about how we transform data to information, to knowledge and wisdom, from Ramona Nelson's work, is really, really crucial to understanding how we can make technology work for us. So this is about designing clinical decision support, alerts notification, and I mentioned that too, because we've was privileged, and I am still privileged and honoured to be working with Sarang Hashemi, who is a PhD candidate, looking at how we can redesign alerts and notifications that actually use the way humans think to deliver better messages so that they can take action at the right time. So, as well as presenting data aesthetically, it's not enough. The current systems and best practices of data science kind of don't take in the social dimensions and the structures into account. So I think nurses have a big role to play in talking about our real world and exposing data bias, because we know that data well collected, even if it's quantitative, can really be empowering too, and can transform the way we work. And how do we do this? We talk about capability. So this is just touching on the nursing and midwifery digital health capability framework, and the domains here that really outline the professional standards that we're aiming for, and a pathway actually to move from beginner and novice to expert, in the same way that we're moving from data to wisdom. So being the largest professional group in all contexts of health and care, it's absolutely important that we're actively involved. So yeah, this is really tricky. Data fields we've never seen, we don't use, detail we're never focused on, noisy interfaces, because ICT's never really seen what clinical looks like. So we've increased the challenge because we work now in hybrid spaces. So there's a lot of unreliable parts to this, and now we've got a heavily pressured contingent environment. So maybe the call is that we still need to address this, and we might need to disrupt it as well. So we've got basically a new line of sight into this existing problem, and we know that this is data navigated decision making. Nurses are amazing at innovating and that kind of connected care. That's what we prioritize, almost at our own expense and peril. There's many shifts where I've never had a lunch break, and I've left late because I want to make sure my patients get the care that they need. So we've still got to address those things. Technology may not solve all of that, or it won't solve it alone. How do we do it? How do we provide high quality nursing care in a digital world? And how do we assure our patients that they're interacting with a human being when they need to, and not with a machine, or a machine when they want to? Or how do we actually continue to support the human element with all these ideas? So the physical environment, the clinical area design, the information systems, they all work together to have an impact on patient outcomes. And we absolutely have to have nurses contributing to the design and the discussion of that. Interestingly, like a long time ago, when I got the job as the Chief Nursing and Midwifery Information Officer at Bendigo Health, my dear sister sent me this. This is how she imagined me. So again, back to the history, and a bit of a problematic kind of I was going to say kind of modest kind of nurse. I guess I have been. But I'm disrupting and challenging in my own way. But I still think kindness is absolutely essential. Florence used statistical methods. There's nothing stopping us from continuing that legacy and advancing our practice and our understanding of nursing, into the future. We need to do this. Our nurses have positive attitudes towards new technology, virtual teamwork, communication, knowledge sharing, but the barriers are really significant and real. Organisational obstacles, management practices, even a lot of still bullying and incivility in healthcare that we have to address. So that's basically it. I was imagining what I would do. What are the next kind of books in my career, and do I jet set off and work somewhere else? Do I make headlines, hopefully for the right reasons, or do we go to space with nursing? Why not? Thanks very much.